Okay, good evening. My name is Vince Trebecki, and this is my microbiology for nursing professionals presentation. We'll be talking about salmonellosis, fibrosis, and bubonic plague. So, starting with salmonella, the causative agent is an enteric bacterial pathogen. It is an enteric bacilli. It's a primary member of the Enterobacteriaceae family. It's gram-negative, non-sporing, and has facultative anaerobes. Okay, so moving forward, as we talk about the causative agent, it is responsible for both food and waterborne illnesses. Some of the symptoms can range from gastroenteritis all the way up to typhoid fever. It's primarily found in vertebrate intestines, lives in the host stool, and some of the most common methods of induction would be eating raw meat, fish, or seafood, or chicken, poultry, and then handling food after you've used the toilet or changing a diaper. Again, going back to the fact that it lives in the host stool. Traveling to developing countries can also put you at risk for salmonella, especially the Salmonella typhi, which is the strand that's responsible for typhoid fever. Finally, handling bird or reptile pets, they are particularly known for carrying salmonella. On the right is a picture of salmonella. So you see the tentacles, it looks like, is that presence of flagella. And then some presence of pili, which is going to be like little fur. Some of them do present as capsules like we see here. And the differences are very important to determine the different virulence. These can also be found in a variety of hosts, not just vertebrates, but vertebrates, invertebrates, and higher plants. The reason we're talking about them today, the medically important ones, are often found in the lower GI tract of humans and animals. Okay, moving on to the mechanism of action. So they colonize in the intestinal epithelium. They trigger their own phagocytosis, which is pretty interesting. They use effector proteins that are injected into the host cell's cytoplasm, right? And then there's this reorganization of the host cell's cytoskeleton. So I think of it like a burglar kicking through the front door of a house and then like throwing things around in the house as he's searching for the valuables, right? This kind of quick and dirty process he's trying to get in and out. And then this results in the bacteria being completely engulfed. The mechanism of action of salmonella, and I want you to point out here. It mentioned type 3 secretion systems, and that's what's involved in the effector proteins. Okay, so when you get infected with salmonella, you're going to present with a variety of symptoms. You've got nausea, vomiting, abdominal cramps, diarrhea, fever. You'll get chills, headache, and there can be blood in your stool as well. The symptoms typically last 2 to 7 days. They can last up to 10 days, though, and it can often take months for the bowels to completely return to normal. Specific strands, like I was talking about, the Salmonella typhi, can result in typhoid fever and be deadly. There are special populations that need to take consideration in harm reduction around the possibly being infected with salmonella. Some populations with increased risk factors, such as the young or the old, people who travel internationally a lot, those who own pet birds or pet reptiles, those who overuse antacids, who have inflammatory bowel disease, or recently used antibiotics. All of those can make you susceptible to salmonella. So if you've had any of that, or if you do qualify in that category, then it is wise to consider being extra careful when handling meat, poultry, and seafood. Um, People with various immune problems can also be particularly vulnerable to salmonella. So people with HIV and AIDS, sickle cell anemia, malaria, or those using anti-rejection drugs because of a lung transplant or an organ transplant, and corticosteroids as well. All right, so how do you test for salmonella? Well, you can take a blood test, but primarily we are testing the stool. Like I said, this lives in the stool of the host. All right, so let's talk about the epidemiology of salmonella. Okay, so it's one of the 4 key global causes of diarrheal disease. All right, that's a pretty big deal. The CDC estimates that 1.2 million illnesses each year are caused by salmonella. 23,000 of those result in hospitalization, and it has a 2.6% mortality rate. About 450 people die per year. Treatment ranges. So some of the major concerns with salmonella is dehydration, just because of some of the symptoms I listed. Obviously, the vomiting, the diarrhea, stuff like that. The fever. These medications, there's medications that can combat these symptoms, like antidiarrheals, and in some cases antibiotics. Things like Imodium can really help. And then antibiotics for severe cases can be prescribed, but it's not always recommended, especially those who are immunocompromised, because it can actually have some negative effects. Antibiotics can extend the amount of time you carry the bacteria and make it possible for you to expose it to other people. There's also an increased risk of relapse for those people who are taking antibiotics to treat salmonella. A lot of times, the symptoms will pass before you even realize that you've had it. So there are some home remedies, some things that you can do just for some harm reduction, especially if you are having symptoms. You can drink plenty of fluids. Adults should suck on ice chips, and children can consume things like Pedialyte. Other things to watch out for, or just things in conclusion to sort of remember when we talk about salmonella. Make sure you're washing your hands thoroughly before and after you handle food. Don't eat raw or undercooked meat, poultry, or seafood. Take special care when traveling overseas. Wash hands after handling bird or reptiles or pets, bird or pet reptiles. And then seek medical care if the symptoms present. And always stay hydrated. Okay, so next we're going to move into fibrosis. There are multiple types of fibrosis. For the majority of my presentation, I talk about cystic fibrosis. So just wanted to make everyone aware of that. Okay, so fibrosis is thickening or scarring of connective tissue that is the result of injury. Right? And that injury can be like trauma, or it can be just persistent use or misuse. We'll talk about some of that. Common types of fibrosis are cystic, pulmonary, retroperitoneal, and mediastinal. Right? In the eyes of cystic fibrosis, what I'm going to be focusing on primarily, we've got genetic diseases, or it is a genetic disease, and so it is passed down from your parents. It is a defective transepithelial C1 gene. It is a mutation of the cystic fibrosis gene, which is located on chromosome 7. And chromosome 7 is responsible for coding the CFTR. The most serious symptoms often occur in the lungs with cystic fibrosis. There is an increased risk of bacterial infections, and we'll go over that. We'll go over that a little bit more. But that bacterial infection comes from this kind of buildup of mucus that happens. So, all right. When we talk about causative agents, in the first decade of life, Staphylococcus aureus is really the primary microbe that we see causing a lot of trouble with fibrosis, especially cystic fibrosis. We also get Haemophilus influenza. And then in the second and third decades, so your 20s and 30s, you're looking at Pseudomonas aeruginosa. Okay. So, Mycobacterium, so non-tuberculosis mycobacteria, right? Most common non-tuberculous mycobacteria is Microbacterium apsius, Mycobacterium avium, and Mycobacterium intracerelia. All right. So, what happens with fibrosis, right? Cystic fibrosis and the mechanism of action. Okay, so cystic fibrosis conductance regulator. That is what that gene is, right? So the CFTR. All right. Basically, what happens when there is a deviation or a mutation, it is misfolded or improperly functioning, and its area of operation is the apical membrane of the epithelial cells of any organ or of most of the organs. So essentially what happens is that CFTR acts as a chloride ion channel, right? And so the chloride is pumped out of the cell, sodium is pumped into the cell, and water can pump out of the cell. This results in sort of a clearing of mucus, and everything kind of flows smoothly right around the cells. When there's this dysfunction, though, the channel restricts the flow of water, and it thickens the mucus, so it disrupts the ciliary clearance. All right. So basically, this buildup of mucus creates this like happy home for the microbes to live in. This often leads to chronic pulmonary infections, inflammation of tissue, and diminished lung function. And this is where we're talking earlier about fibrosis being the damage of connective tissue. Okay, moving on. So the CFTR protein pathway, right? So it acts as like a gate, right? And it opens and closes with ATP, and when things are running smoothly, it's all good, all right? But the chloride channel, right? This ATP binding cassette transporter, this ABC transporter, is made up of three main parts, right? Of this chloride channel. So there's two MBDs, right? And then there are two MSDs, and then there's one domain, right? And so what happens here with these different pieces, they all have their purpose. Okay, so I'll kind of break this down to kind of help you understand basically how this all works. All right, so I used to work at okay, so and back to where we were, right? So there's the non-binding domains and the membrane separating domains, right? So there's two of each of those, and then there's this regional domain, right? And so the way that these work, if you can imagine, right, the non binding domains, they trap ATP so that they can open and close the channel, and then the membrane sliding domains, they tend to act as anchors, so they keep everything in place. They keep it right on the surface of the cell, and then the R domains, they are sort of like the gatekeeper, so they're controlling the flow of everything, making sure everything is moving in and out very slowly. When you have a mutation of the CFTR on chromosome 7, this impacts everything above's area of operation. So we take a look over here at this this slide, and what we have is on the left we see a normal CFTR channel, right? The chloride's coming out, sodium's coming in, water's coming out, right? And everything's clear up at the top, okay? But we look to the right, and what we see is the chloride can't get out, the sodium can't get in, the water can't get out because it's all bound up, and the mucus starts to form on top. So what that does is that creates a bunch of symptoms, right? Typically, it impacts the respiratory, digestive, and reproductive systems. It's like presents as a persistent cough with thick mucus. There's wheezing, breathlessness, increased lung infections due to the microbes living in the mucus, and frequent stuffy nose, as well as sinus infections, bronchitis, and pneumonia. Other symptoms can be foul-smelling, greasy stool, inability to gain weight, intestinal blockage, which we see a lot in newborns, right? And severe constipation. Also, we will see infertility in men only. Some of the complications from cystic fibrosis can be respiratory complications, damaged airways, chronic infections, pneumothorax issues, digestive issues, nutritional deficiencies, diabetes. What else we got here? Blocked bile ducts, reproductive issues, infertility in men, and others can be things like osteoporosis and dehydration. To diagnose cystic fibrosis, every child in the U.S. is tested early on at birth. There is a blood test that will check for elevated IRT, and this IRT level can also be raised based on premature birth or stressful birth. So you'll need other tests to confirm. Those two tests are a gene test or a sweat test. For older children or adults who feel like they haven't been screened, they can also get gene tests and sweat tests done. The sweat test is basically just a way for you put a sweat-producing chemical on the skin, take a swab of it, test to see if it's extra salty, and it can help confirm cystic fibrosis. Okay. Epidemiology here. There must be 2 copies of the defective gene, one from each parent. If you have 1 copy, you're a carrier, but you will not have CF. If you have 2 carriers, so if my wife and I were both carriers and we had a child, we'd have a 25% chance that the child will have cystic fibrosis. There's a 50% chance the child would be a carrier with no cystic fibrosis. And there is a 25% chance that the child will be a carrier or will not be a carrier or have cystic fibrosis. So those are pretty good odds, right? 25% isn't great, but it's not like 75% chance that they're going to have cystic fibrosis. There are about 70,000 diagnosed cases worldwide. We get about 1,000 new cases each year. 75% are diagnosed by age 2. That's because of the testing that's implemented at very early age. And 50% of those living with CF are adults, which is just saying that our treatment is providing, longer life expectancies and quality of life. There is no cure for cystic fibrosis. The treatment is pretty complex and requires a specialist. The goal, though, is to prevent lung infections, loosen mucus, prevent intestinal blockage, maintain adequate nutrition as well. Medications are some of the ways that we can treat cystic fibrosis. You can also use antibiotics, anti-inflammatories, mucus thinning drugs, bronchodilators, ingested pancreatic enzymes to help with the digestive issues. Inrocrafter, which is a drug that improves lung function, weight, and salt sweat reduction, and it's FDA approved. There's also Orkambi, which is approved for people 12 and older, that can be effective on certain mutations, which will combine Invocrafter and Lumocrafter. There are also other kind of treatments. So some of those treatments can be like chest physical therapy. We can get vest therapy, it's a vest that you wear that will vibrate your chest and help break up some of that mucus. Pulmonary rehabilitation, nasal polyp removal, oxygen therapy, endoscopy and lavage, feeding tubes if you've got severe nutritional issues, and then lung transplants are also an option as well. For sort of outside of the box stuff, you've got clinical trials and home remedies and harm reduction techniques. So some of those can be making sure that your exercising is on point, that your nutrition is adequate, that you're staying hydrated, that you're up to date on your immunizations. You eliminate smoke exposure and smoking. So if you're smoking, you need to stop. If you have cystic fibrosis, and then you minimize exposure to bacteria because you have all that extra mucus, which just is a happy home for those microbes to live. Right? So remembering there's multiple types of fibrosis, right? It is a defect of the CFTR protein, right, on chromosome 7. It creates excess mucus due to inhibited ciliary clearing. It's a happy home for bacteria, all that mucus, it really is. Some of the microbes that we see are MRSA, staph, and Haemophilus influenza. It attacks the lungs, digestive, and reproductive organs pretty hard. Early detection and aggressive treatment are the best options. And medication and lifestyle changes, clinical trials, and various types of treatments can also be pretty effective. Okay, so lastly, we're going to talk about the bubonic plague. This is probably my favorite part of this presentation. So, cause of agent, Yersinia pestis, right? And it's gram-negative. It's non-modal, and it's a rod-shaped coccicillus. There are no spores. It's enzootic vector-borne disease, and it's basically there are infected rats, and then their fleas bite the rats, and then they become infected with the Yersinia pestis, and then it's transferred to human by flea bites. So it's thought to have originated in Asia and then transferred west via the trade routes in like the 1300s. Here's a picture of bubonic plague. Okay, so its domain is bacteria, phylum is Proteobacteria, class is Gamma-Proteobacteria, order is Enterobacterialis, family is Yersinia K, and genus is Yersinia, and then species is Yersinia pestis. Mechanism of action, it's a facultative intercellular bacteria. It invades the host cell, prevents phagocytosis, which we talked about earlier, similar to Salmonella. Right? Salmonella created its own phagocytosis, and this prevents phagocytosis. And then again, it's using type 3 secretion systems with a virulence plasmid. This then encodes the T3SS for 6 effector protein substrates, which are going to inhibit phagocytosis and block pro-inflammatory signals. Okay, on your right is a picture of what bubonic plague looks like. There's buboes, which are swollen lymph nodes. They're about the size of a chicken egg. They are tender to touch. They appear in the groin, armpit, or neck. You can get sudden fever and chills from bubonic plague. There is a lot of fatigue and muscle aches. So to diagnose it, we just need a sample of the buboes for bubonic plague. There are multiple types of plague. There's septicemic plague, which you'd need a blood test to diagnose, and then there's sputum or a fluid sample from the lungs for pneumonic plague. This picture here, so I live in Denver, Colorado, and this picture shows a line right through sort of like the middle of Colorado, and it's basically just showing all like plague cases. We do have bubonic plague here in Colorado, and it's in a lot of the prairie dogs, so that's why I attached this picture. It started with the Philistines, as far as we know, in 1320 BC. There's the Justinian plague of the 6th century AD, which killed about 10 million people. Then there was the Black Death from 1347 to 1350, which was about 50 million people. Half of those were in Africa and Asia, and the other half were in Europe. It was about 60% of the European population. And then there was the modern plague from 1860 to 1894, where about another 10 million people died. So we're 70 million at this point. After the causative agent was identified in the modern plague, we were able to start preventing against it fairly well. And then in India and Vietnam in the 1960s and 70s, we saw some of it because it was weaponized. But mostly today it's found in sub-Saharan Africa and Madagascar. About 95% of the cases come from there. So treatment's pretty simple. It's just antibiotics. Once we found the causative agent, we were able to manage it pretty well. We use powerful antibiotics such like gentamicin, doxycycline, ciprofloxacin, and levofloxacin, so Cipro and Levo. Right? I attached a couple of pictures here because this is like my favorite part about the plague is the plague doctor masks. And what a lot of people don't realize is one, the reason that these masks were designed like this was because the stench was so bad that the doctors would put in those beaks, they'd put potpourri, they'd put debris and different things so that they didn't have to smell the smell of death. And then they'd obviously cover themselves as best they could in long coats and hoods and hats and stuff like that. And so it looks really menacing, but it served an actual purpose. And then finally, a lot of people when they think about doctors, I think everyone has like a pretty positive opinion of doctors. But what most people don't realize is plague doctors were either did really poorly in med school or had failing practices, and cities and towns would hire them to come and work with plague victims because nobody else wanted to. So the really successful doctors were not dealing with plague victims. So I always found that a really interesting fact that these were kind of like not the greatest doctors. And I don't know, someday I'm going to dress up as a plague doctor for Halloween because I just think it's really interesting what they wore. All right, so in conclusion, what we have here is bubonic plague that's caused by the bacteria Yersinia pestis. It invades the host cell and prevents phagocytosis with type 3 secretion systems and effector proteins. It's spread by rats, mice, squirrels, and prairie dogs. Fleas bite those infected rodents and then bite humans. There are 3 types of plague: bubonic, septicemic, and pneumonic. It's transmitted by the flea bite primarily, but it can be transmitted through coughing and through sort of like the fluids that come out of your lungs when you cough if it turns pneumonic. The Black Death Plague was responsible for the decimation of 60% of Europe's population in the 1300s. It can be weaponized, and it's something that the United States and the United Nations is very aware of with the rise in terrorism. And the survival rate of modern day is thanks to the strong antibiotics that we have since we've found the causative agent. So that's all I have for you today. Thank you very much for listening. If you have any questions, please send me a message.